My name's Dave Walker. I'm a core faculty member here with the clinical psychology program at Washington School of Professional Psychology at Argosy University, Seattle. And I spoke already in this speaker series, and I get to speak twice. I don't know why that happened that way, but I'm kind of glad because I seem to always have a lot of things to say. My talk is sort of loosely related to the last talk I gave, because I had talked last time about work-related stress and talked about the expansion of the DSM-5 and raised some issues historically in relation to the Hiawatha Asylum for Insane Indians, where we also had a lot of labels going on people, and I kind of developed a really sort of lengthy bridge, I think, and tried to do so in an hour, and I don't know how successful I was. But today well, yeah? Oh, thank you. So here we are. I can report to you that the petition from the DSM-5 reform group that I mentioned has been received by the task force for the American Psychiatric Association's DSM-5 group, and it has been rejected, despite having 12,000 signatures and the support of 14 divisions of the American Psychological Association and all of the various organizations that I mentioned to you last time. I actually passed around a sheet with all these organizations on it. It's been rejected. The request that was specifically rejected was to have outside review of what's going into the DSM-5. So that said, now there's a new controversy about that rejection, so we can kind of watch that unfold. But where I'm going today is onto a somewhat different topic than looking at labeling and looking at labeling the experience of people undergoing stress in the workplace and this sort of thing. I'm going to talk about antidepressants, and I'm going to focus my comments to a certain class of antidepressants, the most popular ones, the SSRIs, selective serotonin reuptake inhibitors. And I could talk about some of the older classes of antidepressants. There's something called tricyclic antidepressants. I won't be spending much time on them because they've been mostly displaced by SSRIs, although you see them, you see amitriptyline being used periodically with people still. But my talk today is kind of technical for those of you who are not as into sort of scientific research. There's a method to my madness in what I'm about to present. It's very difficult for someone like me who's known as somewhat of a curmudgeon to take a position and say, in my service agreement with my clients, I don't recommend the use of, nor do I get involved in managing medication, psychiatric medication. And I actually have an informed consent form that my clients review. And sometimes a question comes up from people who have used SSRIs or other psychiatric medications. Well, that helped me, or it helped me in this way or that way. How come you don't get involved with that? It'll become more transparent why I don't in this talk. But I'm not here to second guess the experience of anybody here who's with me who may have felt that they were well served by these medications, or some family member was well served by these medications. I'm actually here to question the scientific research that goes into the support for those medications. Okay, that's where I'm coming from. And we don't often, in taking a stance like that, think of ourselves in the clinical psychology world as necessarily having a strong enough leg to stand on, okay? And actually there is a very strong leg to stand on, and I hope to sort of surface that for people and question some suppositions around these medications. I first got involved in questioning the use of these medications in my own clinical practice while I was working in Indian country full-time. And a number of incidents happened. One of them was 9 children overdosed on a tricyclic antidepressant on an elementary school playground. And that had come, actually, the medication itself had come from our clinic. So I was quite horrified by that event. It was being distributed by a young guy on behalf of You Can Get High off this medication. And so we had a bunch of overdoses there. About 3 weeks later, we had a suicide in the reservation community of a 10-year-old child who had been placed on SSRI antidepressants at twice the adult dosage maximum level. And I was not directly involved in that particular client case, but I did consult on it with the tribe and pointed out there were some disparities around how dosage was being done. I'm not a psychiatrist, you know, so for me as a clinical psychologist to question the practices there immediately amped up a certain displeasure. Because after all, I'm not trained to give advice along these lines, and so I did anyway. Because I was becoming more and more aware of some phenomena that were emerging around these medications, in particular suicidality, and also the idea that maybe they were not particularly effective. Okay? So where we begin is with our tiny bubbles. And I'm going to try to stick to my notes so I can have time for questions. I'm usually navigating away from my notes, but I'm going to try to be good today. We can begin by talking about the scientific credibility of the serotonin imbalance theory. Many of you may have heard this as chemical imbalance, or the idea that when you are depressed, you're experiencing a brain-based chemical imbalance. And the chemical we're generally referring to is serotonin, which is a very, very broadly involved neurotransmitter. It's involved in sleep and waking, and it's involved in motivation, and it's involved in all sorts of things having to do with mood state, but very widely spread neurotransmitter. And the idea behind an SSRI is that it's supposed to, when you say it's a selective serotonin reuptake inhibitor, it's supposed to inhibit the absorption of serotonin into the cells, the neurons, okay, and keep that fluid in between the cells rich with serotonin. And this is, theoretically, will then alter the mood of the individual and cause them to be less depressed. Okay, so that's the idea there. So that being the idea, I thought I'd put a nice graphic up there. And I don't know if I have enough of these to go around, but we're going to do a little exercise here in regards to that theory. I need 5 people who are willing to be a marketing representative for the pharmaceutical industry. Okay, all right, we got 3, 4, 5, 5, okay, all right. You're all marketing. The rest of you are scientists, okay, research scientists. Now, what I'd like to have, we'll just do this sort of a call and response thing. And what I'd like you to do is, we'll start at the front here. Who's my closest marketing representative? Right here? Okay, great. So I want to mention again to you about the serotonin imbalance theory of depression. We have this nice graphic. This is the kind of graphic that you often see in presentations like this, by the way. And I'd like to begin by asking you to explain to us what this theory is all about. And we have an explanation regarding Lexapro. So you're our Lexapro representative. Go ahead and help us out.
Okay. Lexapro appears to work by increasing the available supply of serotonin. Here's how. The naturally occurring chemical serotonin is sent from one nerve cell to the next. The nerve cell picks up the serotonin and sends some of it back to the first cell, similar to a conversation between 2 people. In people with depression and anxiety, there is an imbalance of serotonin.
Thank you very much for that erudite scientific explanation. Now, I'd like to go to our first scientist. Who's our first scientist? Here you go, Pam. Go, and let us know who you represent there. Go ahead and give us the next quote. The quotes from scientists are in straight face there, bold face.
What do you want me to read?
I want you to read, you're going to read, it's a kind of a call and response. You read the next one.
Okay. The fact of the matter is that there never was a consistent body of evidence to support the theory. George Ashcroft, who was one of the pioneers in serotonin research, abandoned the idea of lower serotonin levels by 1970.
Holy smokes. And who are you, by the way? Over there? You over there?
I'm Professor Lehman McHenry.
You are?
California State University, Ethical Issues in Psychopharmacology, Journal of Medical Ethics in 2006.
Okay, great. Now, thank you. So, we need a Celexa representative. Who's one of my, go ahead.
Celexa helps to restore the brain's chemical balance by increasing the supply of a chemical messenger in the brain called serotonin.
Thank you very much. That was well read. And who will be our next scientist? Go ahead, Carlos.
Although it is often stated with great confidence that depressed people have a serotonin or norepinephrine deficiency, the evidence actually contradicts these claims.
And who are you representing?
Dr. Elliot Valenstein, Professor Emeritus of Psychology and Neuroscience, University of Michigan. Former Chair, University of Michigan Biopsychology Program.
Huh. Okay, great. Thank you. And we need a marketing representative for Prozac. Jeffrey.
I'm Eli Lilly from 1998 January Prozac advertisement, People magazine. And when you're clinically depressed, one thing that can happen is the level of serotonin, a chemical in your body, may drop. To help bring serotonin levels closer to normal, the medical doctors now prescribe, most often, is Prozac.
Okay, great. And let's get another response from a scientist. Go ahead. Yeah.
I spent the first several years of my career doing full-time research on brain serotonin metabolism, but I never saw any convincing evidence that any psychiatric disorder, including depression, results from a deficiency of brain serotonin.
And who are you?
Dr. David Burns, psychiatric researcher, winner of the A.E. Bennett Award from the Society for Biological Psychiatry for his research on serotonin metabolism, 2003.
Goodness gracious. Okay, and we got one more quote there. Maybe we need one more scientist who could read the next quote.
A serotonin deficiency for depression has not been found.
And who is that?
Dr. Joseph Glenmullen, clinical instructor in psychiatry, Harvard Medical School.
Fantastic. Another marketing person. Go ahead.
While the cause is unknown, depression may be related to an imbalance of natural chemicals between nerve cells in the brain. Prescription Zoloft works to correct this imbalance.
Oh, so now it's maybe.
Yeah.
Okay, so we went from 1998, which sure is, in Eli Lilly, and maybe in 2004 with Pfizer. Thank you very much for that. Who will be our next scientist? Go ahead. Need a scientist.
In truth, the chemical imbalance notion was always a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists.
And that's, you're representing?
Ronald Pies, MD, editor of Psychiatric Times, 2011.
Okay. One more marketing person. Go ahead.
Chronic anxiety can be overwhelming, but it can also be overcome. Paxil, the most prescribed medication of its kind for generalized anxiety, works to correct the chemical imbalance believed to cause the disorder.
Holy smokes. Okay, that's from GlaxoSmithKline. Who's our last scientist? Anybody?
We have hunted for big sample neurochemical explanations for psychiatric disorders and have not found them.
Oh my goodness. I can't imagine, but we would be totally confused by the difference between the marketing materials from pharmaceutical manufacturers and some of the experts who seem to have a completely different point of view. Huh? So when we start to delve into this, one of the things that we want to come in with is that the theoretical grounding for antidepressants is shaky. Okay, we want to kind of hold on to that very thought. Okay, and now I'll tell you about Irving Kirsch, who wrote a great book, just came out about a year ago, called The Emperor's New Drugs. And one of his claims is, of course, that antidepressant medications aren't particularly effective. He started that research around the time I was working at Indian Health Service, and I was mindful of that research as it came out. Kirsch's research looked at the original FDA, Food and Drug Administration database at 38 random controlled trials, which are the sort of the top form, the classic form of clinical tests for drugs. A comparison, these are comparison trials where the individuals get the antidepressant medication or a placebo. How many know what a placebo is? Do I need to talk about? Okay, we're talking about sugar pill, whatever. And they do a comparison, and the researchers themselves don't know who's getting the placebo or the antidepressant. Okay, everybody's with that? He was able, through the Freedom of Information Act, to get these original trials for the most popular SSRIs of the day, about 7,000 patients. And all of the random controls trials were used in the initial approval of these 6 most popular antidepressants. So we're talking about things like drugs like Zoloft, we're talking about Prozac, we're talking about a whole variety. Now, the major here that was utilized was the Hamilton Depression Inventory. And you look at people and see how depressed are you on this numerical scale. It's an interview-based scale. And you sum the numbers together, how depressed are you, along a different number of factors. And then you administer the medication or the placebo to see if there's a decline in that. Pretty simple kind of design there. So what Kirsch found in these studies that were used for the approval of these drugs was that placebo duplicated 82% of the antidepressant response. Across all of these trials that he was able to get a hold of, there was less than an average of 2 points difference on the Hamilton Depression Inventory, and only 43% of the random controlled trials favored the antidepressant over the placebo. Now, you only have to get 2 positive trials in order to be approved by the FDA to use a medication, besides the safety and efficacy kinds of studies that you need to do. Okay, so there were numerous studies for several of these drugs. That is, the drug companies had sufficient wealth to mount numerous studies in order to get these drugs approved. So some of the studies were negative and were never really reported. That became a source of curiosity we will look at later. So we're talking about a true SSRI response here within this database of almost 7,000 people of about 18%, okay? And the placebo response, about 82%. And it's very difficult to persuade people when you're talking to the general public that the placebo response, that is the response based in belief of what I'm taking, that it's going to help me, can be so powerful inside a medication regimen like this. But it is, okay? Now, Kirsch repeated this study in 2008, looking at a whole group of what were called the new generation of antidepressants. We have some new versions of fluoxetine, which is a Prozac type. That's the generic name for Prozac. We also have the emergence of something called nefazodone, which was used in the original study that he looked at, but had been sort of revised. That works a slightly different mechanism because it inhibits the reuptake of serotonin, dopamine, and norepinephrine. And so technically it's really called an SDRNI. But it comes under the same general class of these drugs. And he only included studies for those medications where he could get the change scores on the Hamilton for all the trials. Now, I've never used the Hamilton Depression Scale in any clinical setting I've ever been in. And yet it's the sort of gold standard for what's used in these kinds of scientific studies, okay? So I got really curious, well, what does it look like? It is a clinician-administered interview format scale. And I thought, well, I'd like to see it, okay? So I got it for you. And I'll pass it around because this is what we're talking about as far as the criteria for looking at whether these drugs work or not. And what you'll see is, much like some of the other scales we use in measuring depression, you sum it together, you get a total score, and then you're looking to see whether there's change or improvement. So you would like to see a decline in the overall score would signify that the person's depression is going down. And we see that in moderate level of depression, that there's very little difference between the two. Also, we see the reality of a placebo effect. By the time we get to more severe forms of depression, there is a significant difference, and it's a statistically significant difference, okay? That is, when we sum it all together and do a good research design, we find that there's a statistically significant difference between the group receiving a placebo and the group receiving the SSRI antidepressant in what the Hamilton Depression Inventory measures. So it goes down more for the drug, okay? And that would seem to demonstrate something important, okay? But please bear in mind that statistical significance is not the same as clinically meaningful information. Because when I tell you that that looks like about an average of about 1 point of the Hamilton scale, and you see it coming around, you're going to see that's not particularly meaningful in the lives of these people, okay? So I don't know much about the Hamilton scale. For those psychologists interested in psychometrics in this room, I don't know whether that could be an artifact of how, when you get to higher levels of rating, how that might affect people who are more severely depressed in comparison to people who are not, and this sort of thing. We don't know that much about it. But anyway, that's how things turned out. Fast forward a little bit to a fellow named Fernier. This is an interesting study that was looking at random controlled trials from the FDA comparing SSRIs and placebo that did not use a method called placebo washout. Did I explain that yet? No, I didn't. I know I didn't explain that yet. Placebo washout is an interesting thing to do. That's where you, in the beginning of the study, for the first week, you look at the people who are responding to the placebo. And those people who are responding to placebo, you say, you're pretty much booted out of this study. Okay? We're not going to look at their data. Okay? Placebo responders in the first week are not going to be looked at. Okay? Now, from a statistical standpoint, that does some interesting things. It gives more salience, more valence, more power to what your antidepressant is going to do. If I said to you, in the first week, those who respond to the antidepressant will not be counted. Okay? We'd say, well, that's kind of biased against the drug, isn't it? I mean, what if it's working, right? Okay? But no, we say that in this method, which is thought to control for placebo effect and more carefully illustrate the antidepressant effect, but in reality tends to statistically emphasize the antidepressant effect. This has been one of the criticisms. So Fernier said, I'm going to try to control for that. I'm only going to look at studies that don't use a placebo washout phase. And he was able to pull together data on 718 patients. And here we have the Hamilton Depression Rating Scale scores. And this was an article, it was a major article published in the Journal of the American Medical Association. What are we looking at here? We have the estimated placebo change on the this is the average level of change in scale scores here, okay? And we see how the placebo is at higher levels of severity. Placebo is also affecting people as far as change in reduction in their score or, in response to the placebo. And here we have the medication, which is slightly higher, okay, in that effect, okay? The overall findings of that study were that 70% of people did not benefit from either placebo or antidepressant. And here's a quote from the researchers themselves. The magnitude of benefit of antidepressant medication compared with placebo increases with severity of depression symptoms and may be minimal or non-existent on average for patients with mild or moderate symptoms. So this is just an introduction to how some of this research has worked, and it's not particularly strong, okay? It's not particularly strong. And that's just one of the places I wanted to take you, because the next thing I want to focus on is another assumption. Antidepressants should be less risky, less costly, and more beneficial than non-invasive, non-medical approaches. Sounds like that would be a good criteria for us to look at. And we can look at it. And here's a nice little study. And this is the one that was done at U of W. Do you remember that back here, a couple slides back, we do have people who seem to be responding to medication in each of these conditions, especially at the severe levels, okay? They appear to be responding, all right? And we'll call those people treatment responders. So there's been some studies of these folks who are called treatment responders to antidepressants in comparison to being in just therapy alone conditions. You know, there is a lore in counseling and clinical psychology that basically says what? You're supposed to have medication and therapy together because that's sort of the best combination of helping someone, right? Right? So this research looks at that. And we're looking at it kind of in an interesting way. What we have here in this nice little UW study is we have a situation where we have the comparison between a medication condition, which is right here. It's like these little squares, okay? So, we're looking at people as far as relapsing back to depression. So all these are treatment responders, and they're receiving different things. They're receiving medication, or they're receiving a placebo, or they're receiving a kind of therapy called behavioral activation therapy, or they're receiving cognitive therapy that's a manualized kind of cognitive therapy approach. It was a 12-week long program, okay? Right here, everyone was put on placebo, okay? The medication, in other words, was discontinued, all right? And here we see those people who we call treatment responders. They know the difference between I'm not taking the real medication anymore. They start not responding, okay? You see that? Everybody with me? Okay. But look at the folks who are in the other therapy positions here. And these are folks who are in behavioral activation position here, okay, or in the cognitive therapy position, and they're receiving just therapy alone, okay? So they're continuing to respond. Now, are they going to therapy at that time? No. They've already been through therapy, okay? And this is just based on follow-up studies. How are you doing? Okay, how are you doing in therapy? We have a more invasive approach to depression, and we also have a more costly approach. Okay? This flies in the face, by the way, of the sort of prevalent wisdom out there that antidepressants are sort of more cost-effective. They are not. And I'm leaning here not just on the Dobson study that I'm showing you, but also on the work of a fellow named David Antonuccio, who shared some of these slides with me. He's down at University of Nevada Medical School, and he's a real guru on this kind of research. So we also would like to know what are the relapse rates among those people who are taking just the antidepressant medication. And we see that the relapse rate is actually pretty high. Those with prior cognitive psychotherapy, about 15% will relapse to depression, moderate to severe depression. And those with just taking the antidepressant medication will, about 55% of them will relapse. We want to ask the question, is there an upside? Is there an upside to SSRIs? Because I'm being so tough on them today. And yes, there is. There is unwanted psychological side effects. And this is another study that was done at U of Dub. I'm really pleased with U of Dub in doing this kind of research. This was something done by Bowling and Kohlenberg in 2004. And what they did was they checked in with 161 treatment responders. Remember, these are people who are responding to SSRI. And they also checked in with people who were not treatment responders. They wanted to compare them and how do you experience the use of this medication psychologically, okay? And it's very interesting because what I have up here for you to show you are the unwanted psychological side effects of the non-responders, okay? But and I don't have a separate one for the treatment responders, but I wanted you to see the complaint, the primary complaint of the non-responders to the SSRI. And what is it? Can you make this out over here? Narrow affect. Which begs a question conceptually. It begs the question whether the people who are the treatment responders see that narrowing of affect as a positive thing. It means like you have narrow emotions, you can't feel very much, you don't have a lot of range to your emotional life, okay? You're just sort of numb, sort of emotionally numb. Yeah, and I had a client one time who told me during a psychotherapy session while she was on an SSRI antidepressant, she said, I really am feeling like I would like to weep right now, but I can't do it. I can't make myself do it. I just know I want to feel, but I can't, okay? And so this group of non-responders is saying, this is an unpleasant thing for me. I don't like this feeling. Whereas maybe, you know, and I don't know what literature's out there. I've not seen many studies done like this that would help us understand whether, it wouldn't be a great dissertation right there, whether that narrowing of emotion, that narrowing, that numbness is attributed positively by those responding to the SSRI. Okay, look at all the other stuff up there, by the way. You know, we got about 45% of people who were non-responders saying that this was the primary reason that they quit this drug. but almost 35% saying, I didn't feel like myself. People reporting loss of creativity, an inability to cry, a sense of apathy. And this goes all the way down to all sorts of other little things that they complained about. So wait a second now. What I've said is there seems to be some unwanted side effects. There seems to be some additional cost. They don't seem to be particularly effective. Here's another assumption. An antidepressant should not make you want to take your own life. Don't you think that seems to be a pretty good assumption? Right. And you know, I became aware of this issue while I was at Indian Health Service and after the terribly tragic suicide of that child who was, like I say, only 10 years old and had only been on this dosage of twice the adult level of Prozac for about 3 weeks when they took their own life. There have been anecdotal reports of dose-prompted intense suicidal and homicidal promptings in a subset of people taking antidepressants, not just SSRIs, since the mid-'80s. Okay? And they've come up and come down in the popular press and this sort of thing. But a fellow named David Healy in the United Kingdom, his psychiatrist, looked at the original research, the original clinical trials on SSRIs and deduced that the suicide risk per 100,000 people was 3.4 times higher than the general population and was attributable to the antidepressant itself. Okay? And this was because he was looking at healthy trials. You know, they do the safety and efficacy trials for these. So it was looking at trials of people who were not being studied for depression, but being studied for the safety aspects and finding this elevated suicide rate. Okay? And this was scandalous. Okay? Everybody pushed back. Now, interesting thing about David Healy, he gave a talk at the University of Toronto. He'd been hired as a faculty member. And he was using medication with some of his clients. He's just very conservative about its use. And he's talking about this finding, okay? And he was being offered a position with the faculty there, and they withdrew their offer of a position on the basis of this research that he had brought out. And he got really mad because he sold his house in Wales and he was about to move there to Canada. So he sued them and he won. And he made them hire him as a basis of the suit and pay him $200,000, and then he quit. I kind of like David Healy. Okay, he's kind of an interesting guy. He's still around. What happened was the reanalysis, there was a reanalysis and replication of his original work worldwide, which led to limits and even bans in Canada, United Kingdom, New Zealand, Australia, Germany, and other places. The FDA was very slow to react to this and eventually acknowledged suicidality was twice as high among adolescents and children taking SSRIs than those taking placebos. There is ample evidence, Richard Legendre, I can give you the reference, of a conspiracy, really, at Eli Lilly to suppress evidence of the suicide potential of Prozac in particular. Okay? So they really went out of their way. They acknowledged it, and then they tried to keep it out of the press. Looking at that those FDA reanalysis of the original antidepressant trials, we do see that here's the odds ratio right here. And look at the TAD study. The TAD study is a more recent study that stands for the treatment for adolescents with depression. It's a National Institute of Mental Health study. And what we see here is a variety of conditions. We have a combined cognitive behavioral therapy and fluoxetine, which is the generic for Prozac. We have fluoxetine alone. We have cognitive behavioral therapy. We have alone, and we have placebo alone. Look at, by the way, the extent of that placebo effect. It's pretty strong. You can see that for yourself. And you can begin to wonder how big a piece of that is here. Do you understand what I'm saying? That's what you should always do when you're looking at this kind of information. Here's cognitive behavioral therapy, by the way, right there, alone. And we see all this as the acute response. So what we're looking at in that study is a placebo response that is, placebo response is about 86% in this study on the Children's Depression Rating Scale. And the true fluoxetine response is about 14% in the TAD study. Harm-related adverse events were something that the researchers were pretty upset about because they were working under a big grant from Eli Lilly. And they found that they had about twice the incidence in the conditions using fluoxetine of harm-related adverse events. They widened the definition of that. So anything from suicidal ideation to trying to cut yourself or trying to kill yourself or kill other people was called a harm-related adverse events. And there was about twice the incidence in the conditions where the adolescents were on the fluoxetine as in the no fluoxetine conditions. When we look at psychiatric adverse events, which is something a little bit different, we're talking about reports of irritability, reports of manic behavior, or chronic fatigue even, we see a much higher incidence of those kinds of adverse events while on the fluoxetine, up to about 18% of the kids reporting that, and somewhat more in the, or somewhat less, I'm sorry, in the combination treatment, which there were some inferences around the idea that the therapist could talk to you about those adverse events and help you sort of cope with them as you were going through them, so that was one explanation for that. We also see, of course, people reporting adverse events while they're on a placebo. That's interesting. Okay, that's pretty interesting in itself. We don't know why. People don't report very many adverse events while they're just in the psychotherapy condition. So now we see another kind of circumstance where we're not seeing that kind of harm-related stuff going on. Here's another slide. Got to look at this one kind of carefully. This is comparing combined response to the 36-week follow-up, looking at the changes over a long-term experience with these various conditions. And in principle, we want to say, well, like we've always said, the combination of medication and psychotherapy is somewhat better than CBT alone or just fluoxetine alone, which are about the same. But where you would be making a huge mistake is not looking between the lines and realizing this is a product of placebo washout, okay? And we don't know how much placebo goes into this, right? So remember when I sort of rewind you back, it's about maybe 14% of the treatment there. Now understand, we got to say that CBT also has a placebo effect. Okay, people say, I'm coming to talk to somebody and I feel better, okay? But look at this. This is not taking any medication, and the difference between not taking any medication and the combined approach with all those adverse aspects to it is only about 5%. So now we look at suicidal events in particular. Holy moly. When we look just at the fluoxetine condition, we see a rate of about 14.7%, and the researchers were scared to death by this finding. Okay, when you're only taking the drug itself, had about almost 15% of the kids engaging in suicidal behavior while they were on it. And when they were in the CBT condition, about 6%. Okay, that's CBT alone. That's not combined. Here we see a slight increase, not statistically significant, in the combined condition, and we can wonder, is this because the therapist can talk to them, give them coping mechanisms for their suicidal behavior and this sort of thing? But are we then talking about in the combined circumstance, which is kind of like I'm saying sort of the traditional way people think, actually it's more hazardous and that we need to do more kind of checking in and making sure this kid doesn't get more suicidal while they're on the antidepressant? And we'd be safer if we were just in the psychotherapy alone? That's what the kind of question that the researchers actually did not address. They said this phenomenon was an aspect of adolescent depression and how it works, okay? And I think they probably did have to say that given their funding sources. What about sex? And I always can perk up people's interest, especially at lunchtime, as the blood sugar starts to hit in, and you've all come in to see me, and I so appreciate it. I'm talking along here pretty fast, but if I say sex, I know I'm going to get your attention, okay? Wouldn't it be depressing if antidepressants interfered with sex, okay? And so, let's take a look at that. Here's a wonderful little study done of quite a lot of people, about 1,000 people. The data was collected in Spain. It was reported in the Journal of Clinical Psychiatry. It did not receive much general media attention, but it was there in Journal of Clinical Psychiatry. Didn't hear much about it. They looked at people who had previously normal sexual functioning, or reported that, who were being treated now with antidepressants. And they were asking them about sexual dysfunction in their lives within 2 months of starting the antidepressant. They interviewed 610 women, 412 men. They used the psychotropic sexual function questionnaire, which I don't even know what that is. Okay? And 59% reported sexual dysfunction. 62% of men, 57% of women reporting this dysfunction. That would be kind of depressing. And people might turn to solutions. And there are pharmaceutical solutions for sexual dysfunction. It just so happens that at another end of our business, we're able to offer you a whole variety of things that you can choose from. In fact, there are things now for women. We can help women with sexual dysfunction. And there's did you know that women's sexual dysfunction is an underdiagnosed area? It's underappreciated. We're not giving sufficient attention to women and sexual dysfunction. So we need to do that now, because it seems as though we're getting a rise in that phenomena. And isn't it time we started to respond to women? It's not fair. It's not egalitarian of you not to respond to the sexual complaints of women, right? Which have been potentially, induced by antidepressants. Okay? And here's some of the reports across the 6 major drugs here. Depending on what you look at, anywhere from 25 to 50% of people taking antidepressants. Look back at the research I already told you about and ask the following question. Aren't these drugs better for you if you don't want to have sex? Okay? They seem to have a stronger effect in that area. Okay? And believe it or not, they have been prescribed in certain sexual offense circumstances, forcibly prescribed by certain court order kind of situations. That has happened because of that ability to bring about that effect. So where have we been? The evidence-based practice regarding antidepressants. They're not based on any sound biological theory. They're not too much better than a placebo. Okay? There are these people who are these treatment responders, but we have these tools being used in measuring them that are somewhat questionable. There's more risk of adverse events and side effects compared with other treatments. They may increase suicidality. They may make clients irritable, manic, fatigued. Many people report unpleasant psychological side effects. They actually interfere with sexuality more effectively than depression. And we can wonder, does this phenomena even potentially generate depression in some people? The idea of not being able to perform or have fun in a very important part of your life, okay? And we could say, with all they're up against, how do these SSRIs remain so popular? Because they are really, really popular. And I mentioned some of this last time I spoke, but 5 of the top 10 prescribed medications in the United States are antidepressants, SSRI, antidepressants at that. 1 in 8 Americans has taken antidepressants in the last 10 years. 1 in 4 women aged 40 to 89 is currently on such medication. The revenues for manufacturers resulting from antidepressant sales are $13 billion worldwide. There was a 400% increase in the use of SSRIs between 2005 and 2008. And the primary mechanism for people to obtain an antidepressant is through a meeting with who? Their psychiatrist?
General practitioner.
There you go. And that's been the marketing strategy of the pharmaceutical companies all the way along, to completely bypass the mental health folks, okay? And bring that to the primary care physician through marketing, your television commercials, your little bubbles, and your serotonin explanation. And that's worked very well. But we could hope that those primary care physicians would turn then to their professional journals and say, by gosh, I'm going to read up on this stuff before I recommend it to my clients. And so if they were to do that, Turner did a nice little study here where he looked at the reporting in the psychiatric and primary care journals of the original FDA trials for these various medications that you see all along the bottom here. They're numbered from 1 to 73, okay? Well, Turner discovered that there were some missing trials in the literature, and so let me put them in there for you. There you go. Whoops. So these things were, not all of them were published, okay? And when you see the actual breakdown by drug in the review, you find that, well, there are some that get a little bit more positive review, but all of them had negative findings in the original FDA. So this is what the FDA has seen, not what the general public has seen, typically, except for the Turner study. I feel, as a licensed psychologist in the state of Washington, that, and from an evidence-based practice standpoint, that I do have two very solid legs to stand on in saying I don't recommend the use of, nor do I manage the use of antidepressants. And that's pretty much where I'm coming from, and I've showed you as much as I can about why in the time allotted. And I want to thank these folks for helping me, and thank you very much. So, hey, I ran out of time, but I did it, and you all came, and thank you so much. I really appreciate it.